Oh,
Sounds great, Rick. Thank you. Hi.
Epic. Going to PAX imaging.
So, so I will show the pictures and we'll put it all together. So basically it says evolving subacute hemorrhage. So that's what we're looking for.
Okay.
Subacute means it's no longer the acute phase.
Mm-hmm.
That's the phase when things become more liquidy rather than a blockade.
Okay.
And then with a commensurate decrease in surrounding vasogenic edema, that's the swelling.
Okay.
So everything is what we wanted to see. So I'll put the picture up, and I put it up in comparison with last year's follow-up picture.
Okay.
You had a picture in July last year.
Mm-hmm. Wow, that's amazing. Look, guys, there's my eye.
So yeah, so the picture, these are teeth.
Okay.
As we can see, you've got all of them.
Yes.
And then we have the nose. You can see the nasal cavity, and you have the eyes, the lens of the eye. So this is the top of the head. You pop it. This is what you see. And ear folds is right here. So, and these are arteries. This is artery. So when you look at this, this is to your hearing apparatus.
Okay.
This gives you sensation to the face. This is the brainstem. The Mickey Mouse part is the brainstem, top of the brainstem, and then there's this sort of all kind of that's the pons, and then as you go at your level, this thing is centrally localized. See.
So it's right in the center.
Yeah, pretty much.
Jerk.
So that is why that we did not. I did not recommend to go because it's centrally located. So to split open the brainstem is something that we do. It's much less risk to split open the spinal cord. We do that a lot more commonly than the brainstem. It's because in spinal cord the fibers tend to go vertically down. So it's already done all the crossing, and there is still some crossing fibers, but in the brainstem there are a lot of fibers still crossing. So when you split, wherever you split, you can hit those. So if you split vertically, then you're like, if this is draped with cables, you can sort of drape this cable away and find your space, and once you come out, the draping parts will start to fall into places. And you still can cause a lot of swelling because you're manipulating the area, but you're not severing the fibers, at least when you stay vertically.
Sure.
But in the brainstem, there are a lot of things are crossing. So no matter how you go inside, you're going to sever some fibers, and that will be a big concern. So the difference now is that, not that we feel that. So the difference now is this is, February. This is July. This is just the picture we have today. The difference is now is, first of all, you have a lot more swelling. See, these are all swelling, which you didn't have before. See, you should be looking, see that, see the nice springs, the tissue itself. See, see, this one is the same as this one.
Oh wow! Yeah, I see.
See the swelling? Before it was even much more extensive. But when you come down to see all that swelling, and then if you come down here, see that's for comparison. So when you get down to here, see what happens is down to here, you see this portion of it is come to the surface of it. See, you see what happened to this one. What happens is when you hemorrhage, so this is the center of it, right? And then these portions are actually blood. What happens is the blood itself then don't typically sever the fibers, because blood, when it first starts bleeding, it's a liquid. and liquid has ability to dissect in separate fibers rather than cut right through. It's not a sharp. But when you do your dissection, we are, no matter how gentle you are, it is an instrument. So you can spread and do all kinds of things, but nonetheless, it's not like the liquid itself. So the liquid has presented itself more to the surface in this area, so we can go right here, and this will be have a layer of hopefully just blood clots that's now liquefied, and that's what we're waiting for.
Okay.
Also, we also wanted to wait to get her a little stronger, because everything we do in the brainstem is a fairly significant beating to the system. So I always say that if you a person and then someone traumatizes you by hitting you and you're on the floor, but that hit, let's say, requires some repair, but the repair itself requires another hit. So rather than hitting you right on the floor while you're still down and with surgery, then you might not get up. I wait a little bit and see if you can get up a little bit, then hit you with the surgical repair, then you're down again, but then at least it's not, so it's one of those, it's a very intuitive approach in terms of, but if we wait long enough, this thing has bled 3 times with the last 2, one after another. It's proven itself to be a very, very aggressive kind of a lesion. So you sort of, you say, well, I'm now an honest man. I went to jail once for stealing, and then after that, the person stole another 2 times. Then you start to say, well, this honest man concept does not apply anymore.
Yeah.
So the first time we'll say, well, maybe it won't happen ever again. So we'll just wait, because you have to go through the. So right now, I think we are going to go and then see, this is a little room made between this. See, right now between here and the brain, it's just like that. So when you dissect it, you have to maneuver the brain around it. But here you have a pocket of blood now.
Yeah.
Okay.
So it cushions things a little bit.
Yeah.
It doesn't make, it's not like walk in a park. No,
Yeah.
but we that's why we waited for 2 reasons. One, she's a lot stronger now.
Oh yeah.
Yeah.
From
Just the
Thursday
talking,
to today.
yeah. And the second is that to wait for the blood clot to liquefy. So when we first have fresh blood, it looks like a mass, and it's very sticky. It's very intrinsically adherent to the surrounding brain. So if you try to get this thing out, the blood itself will be adhesive. So it's very hard to get it off the brainstem without more manipulation. But now it's more liquidy. So we're hoping once we split, the fluid will ooze out, and it has done a dissection for us. And then we have a relatively more clean margin on this cavernoma, which is this thing. And then it can deliver itself out with much less trauma. And then that thing looks like a small blueberry.
We'll get that out too, right? That's
That-
coming out?
Yeah.
Yeah.
Yeah, that's coming out. So the process is, tomorrow we run an angiogram. You've had that first time go around. The reason we run an angiogram, there is probably only 1-2% of time. This is not a cavernous malformation, but arteriovenous malformation. The difference is, one is arterial blood. That you go in, you piss it off, it just starts to bleed.
Yeah.
And you can't buzz away in that area. If you do, it's just, you can stop the bleeding, obviously, but it's a very, so we don't go and do that in that area. That will be treated with focused radiation, which will actually scar that shut. But it does take a year or 2 if we do that.
Okay.
So that's only 1 or 2%. I don't expect that's the case, but it's not 100%. So we run another angiogram before we go in. We don't want to be going in as surprised. So that's the reason for the angiogram. And then Wednesday, so tomorrow, I'll come in. I'll have to put some special markers on your head.
Okay.
And the special markers are to be used. Tomorrow you're going to get another MRI at night I've already talked to radiology around 7 o'clock-ish.
Okay.
Those MRIs will be done with the markers on.
Okay.
And you wear the markers throughout the night. And then before surgery, then we put, say, we name this marker number 1, name this number 2, 3, 4, and then there's markers on the MRI scan. So when we put a probe on this marker, we say, hey, that's should be that marker on the 3D model, and then we correlate all that, and then it builds a 3D model of your brain with the highest accuracy that technology would allow.
Nice.
And then when we go in, I suspect I'm going to see a purplish surface. Tell me that's blood underneath. But if I don't see that, I cannot start dissecting the brainstem just anywhere. Obviously, I have a very good idea where it is at, but we're talking about a millimeter kind of a thing.
Mm-hmm.
I'm not willing to go a millimeter unnecessarily dissecting that area. If it's even a millimeter off, means a lot. So with that navigation system, then I can, in case I don't see, which I feel that with this surface right here will be purplish looking. It will be different from this. And then there is a midline right here. You see it's already opened up a little bit. You just so it is something that I anticipated to actually visualize it under microscope. Then the 3D model is not as critical. I will again double confirm just in case I was hallucinating or something, you know. But I will confirm it again. But if I don't see it with confidence, then the 3D model becomes so. The first would be me visualizing the area based on the anatomical understanding of it and direct visualization under microscope. So the 3D will be confirmatory. 2 will be, hey, this is the anatomical area. I don't see precisely where that little blood area is, but this is what I believe based on anatomy. Now that's not as accurate. Not that much off, but maybe a couple millimeters off. And then the 3D becomes the primary localization. If it puts a probe here, it says right here, then that's where I go in.
Okay.
So that's why we do that. So that's the plan. Tomorrow, angiogram, I don't anticipate we see anything unexpected. There's might be 1 or 2%. We see that. If we see that, no more surgery. We do the radio surgery, which takes 1 or 2 years to actually for it to work.
Okay.
But surgical option is not an option. And I don't expect to see that. And then we do I will come and put all that stuff on, and the MRI at 7 o'clock. And in the morning on Wednesday, you'll be wheeled out. We will talk about whether or not you'll stay here. You'll go to a regular room, tomorrow.
Right.
And then, but after surgery, you'll be in the intensive care unit. After surgery, you likely will have the breathing tube left in for overnight.
Okay.
Because first, it's going to be a long surgery for you. It will take as long as it takes. So typically, my part may be 4 hours, 5 hours, 6 hours, whatever it takes.
Okay.
Your part will be adding a couple of hours before and a couple of hours after. But for you, you're going to stay intubated because the general anesthesia length of time is going to weaken your breathing muscles a lot.
Okay.
And especially, for you to handle your saliva. Right now you can, but with effort. So it's not like us, So there is quite a bit of weakness in even handling your own saliva. So we don't want to take the breathing tube out, you choke, and then the saliva goes into your lungs. So we're going to leave it in. The next day, we're going to try it. Because next day, you start to wake up a lot more, because the general anesthesia should be overnight, should be completely out of the system. In other words, we don't want to get the breathing tube out while you're still kind of under some influence of the general anesthetic agents.
Is it going to go down my mouth or in my throat?
In your mouth
In my
first.
mouth. Okay.
So we go do that. The next day, if we can get it out, then it may not be right away next day, depending on how we feel. It's not a precise cookbook criteria.
Okay.
It's kind of just to examine and do different things and play with the ventilator, see where your lungs are at. And then if we can take it out, we take it out. But if there's any concern, A, after we take it out, there's a concern, or B, we're not even willing to take it out, then you get an airway in the throat directly. And that thing goes into your windpipe while your food pipe is behind the windpipe. So the food pipe is here, windpipe is in the front. So the windpipe, when you swallow, you know, it's very complicated. You don't fall into the windpipe.
Mm-hmm.
So, but when you put the airway directly into it, the airway has a cuff around it. So it kind of cuffs up a little bit, so stuff, even if it drops in, it minimizes the chance of stuff passing through into your windpipe and choke you or cause damage to the lung. So that would be the tracheostomy, and that's a potential.
Okay.
And then do expect most of the time when the manipulation is done to the brainstem, it's going to swell up, and you're going to have more deficits. Right now, you say, well, I've had enough. I can't feel any, you know, all that stuff. And I can swallow, but I can't still pass the swallow thing. So, but I can at least sleep through the night without choking on my own saliva.
Yeah.
So those things could get a lot worse. But you're 38.
And long term, getting this out.
Well, with the three times of hemorrhage, I don't know if anyone would have a choice.
Oh, well, then there's that.
Well, you can always, you say, I choose to believe you even though you killed 3 times. I say, well, you know what?
Yeah.
Oh, attempted murder. This time we can't say kill, but
That's right.
yeah, but this area, attempted murder is actually accurate because this area can be lethal quite easily, actually. Because if it shut down, if the hemorrhage is violent enough, you'll stop breathing, like you will be instant death. So with the surgery, it comes with all the risks that the hemorrhage itself will do, but in a more controlled fashion. And the hemorrhage can cause things that are permanent, so can the surgery. But again, surgery is something that we only recommend when we are clear the behavior of what's in there is not acceptable.
Yeah.
So the surgery probably will give you at least 5 to 7% of unacceptable long-term problems. And then we're not sure, looking at you, we're not sure, hey, can you eventually get normal sensation? We're not sure.
Okay.
Can you eventually swallow, or it's always going to be tricky for you to swallow. So your swallowing capacity will never be as good as before. Regardless of if this thing is magically gone without surgery. The injury that is already there is no different from someone hits hard on your shoulder with a baseball bat. That shoulder will not be the same. You've had that already.
Okay.
But doesn't mean you cannot swallow, it just means that in the future, let's say you're all fully recovered. That doesn't mean you recover back to 100%. That simply means you recover as much as you can.
Okay.
You probably most likely will still have the sensational problems, not to the same degree as you are now. Because right now, if you walk, you don't have the feedbacks. You don't feel, it's not giving your brain information when you land your foot down. Then you have to use your eyes, look around, and use your eye to collect information. Otherwise, the brain cannot initiate enough calculation to tell you how to balance yourself, how to do the next step. Those things will be still having residuals. But at your age, it's hard to know how much residual will be there. Sometimes it's very subtle, only clear to you, and even sometimes people touch you, so some areas not quite right, some areas are as normal as I can imagine. Because after a while, you don't know what's normal.
Yeah.
Because this is all evolving.
New normal.
Right, because everything is different now, right? And as far as the swelling goes, with the way you're going right now, I believe eventually you'll be able to swallow pretty much everything, but you will be different.
Yeah. I'll probably choke and stuff sometimes.
As you get older, it's going to be worse. So that's why also we got to get this thing out. Now, get this thing out runs through all the risks this hemorrhage can do to you.
Yeah.
But it's just in controlled fashion. And then, so the plan is keep you on a ventilator. So you will not, by the time you kind of get fully waken up and stuff, hopefully the ventilator is off and breathing tube is out. But don't be traumatized when you wake up and there's a trach in your throat.
Yeah, I'm ready for it.
And then a lot of times that trach, as soon as you can breathe and protect your airway, it comes out, there's a tiny bit hole there.
Okay.
Any questions? Now, we're not talking about just the sensation. Everything the brain does has to go through. The brainstem is about this big.
Mm-hmm.
So this is in relation to, so this is the spinal cord right here. You have swelling down to the spinal cord.
I see.
So that was a lot more just a couple weeks ago. See, that's all swelling. So, but this is very small in size. In other words, you know, everything channels, first channels through this Mickey Mouse structure, and then it gets smaller and smaller and more dense when it comes to this area. Just, you know, it just becomes smaller.
Yeah.
So that's why a millimeter is huge once you go into that area. So that is why, you know, when it first hemorrhaged, we say, oh, well, you know, maybe it won't happen ever again.
Yeah.
Which in many situations it doesn't for long years, many years to come. But now I don't think we have that option anymore.
Okay.
And then so this area controls everything. The only thing that it does not control is your intelligence.
Mm-hmm.
Yeah, I don't know if it's yeah, what
That's
happens.
good or bad.
Yeah, because the intelligence, everything else from here down is following brain's instructions and providing brain with information, but it does not do any cognition. In other words, you cannot perform cognitive tasks with your fingers. It is still here. And then so all the things that's perceived here is not passing through here. So the only thing that it doesn't do is the cognition. But everything else, movement, heartbeat, breathing, swallowing, living. All the survival functions are there, with the exception that what marks us human beings is intelligence. So it's actually not so, you know, so-called locked in is exactly that. Everything else has failed, and people can only wink their eyes because the nerve passing through their eyes are above that. They kind of yes, no, and or you know kind of, but otherwise they truly understand everything, and they just can't. They can't even speak because the muscles controlling that can be compromised. So that is a bad situation.
Yeah.
You'd rather not to have the intelligence, then you would not be aware of things. But in this particular case, all survival capacities are there, except the intelligence. So everything the hemorrhage can do will be everything except the intelligence. Everything the surgery can do negatively is everything but the intelligence.
On the 1% chance it is the AV malformation, during the radiotherapy, the 2 years, does it take about the same? Do you get the same outcome with the radiotherapy after the 2 years of radiation?
Yeah. So if it's a AV malformation,
Yeah.
it's going to be a tiny one.
Okay,
Because
right.
the size of that
It
will
would be
respond to very well to radiation.
Okay.
The success rate will be well above 90%, and it will scar down.
Right.
The only thing is you take on that risk of it just
The time.
bleeds.
Yeah.
Now, if it's AVM, unfortunately, I will get a lot more worried, but there's nothing I can do about it. Because AVM is a high pressure. It's a arterial bleeding. When it does that, next bleed could just take you. Yes. But I can't go in to do surgery on that.
Yeah.
Not just I can't.
Nobody
It's
can.
not. It's beyond human capacity.
Yeah.
But radiation can do it. I don't think that's what we're dealing with. We had an angiogram before. It's just that this guy hemorrhaged within days, twice. Then we say, well, gee, that's not a typical behavior of a venous blood.
So just double check and make
Just
sure.
double check before we go in.
Okay.
The angiogram gives you 1% risk of growing injury, and a stroke, and that wouldn't be much of an issue. But it's 1% or less.
Yeah.
and you will be pretty much a little bit sedated. We can't sedate you a whole lot because you have to lay flat. We still have the concern about your airway because you can't handle your saliva. Sometimes with just a little bit sedation, you kind of get lethargic and you start to be pulling your saliva. Then we kind of quit the angiogram.
Okay.
Yeah.
All right.
How many days after the surgery will she
Rehab?
You think out?
no, well enough for
Work?
for me to for her to know I'm here.
Yeah. So I would hope that if the airway swallowing, the airway protection is not an issue. I'm hoping that things will clarify in 2-3 days. Like, okay, can we take the breathing tube out safely? Do we need to trach her? And does she move? Does she feel? Does she all that? So 2-3 days will probably clarify things. Now, within 2-3 days, if you say, oh, things look very bad, I will still consider that to be swelling and things. A lot of times, the swelling of the brainstem don't really go away for months. So that is why she's on steroids. She has been on steroids. We're waited because we're gonna go and cause more swelling. It makes if you're already maximum swelled up, you go in and do some more swelling, then you bump off the brainstem.
Can we say she's going to be in the hospital X amount of time?
I think easily a few weeks.
Yeah.
That might include the rehab and all that.
Yeah.
I don't think you'll be returning to work every day. So you might want to start the paperwork for short-term disability for 9 to 1.
No.
Would okay. I know. We'll be okay.
I'll be okay, Carmen.
I'm sorry I was blunt.
No, I'm glad.
No,
I
it's
prefer
good.
it, actually.
Yeah, I think it's.
You instill a lot of confidence.
Oh, thank you. But 6 months is something that probably be good to start some paperwork. Because you're gonna have a lot of trouble if you don't feel.
Yeah.
I mean, it's just actually in severe cases. In your case, it's actually not too bad. You're able to hold a cup. Some people can't even hold a cup without looking at it because they don't know how much pressure to do it. So I have patients can't even eat a toast because every time they pick up a toast, it's crushed. Or if they don't know how much pressure to add because they have no information. And by just looking at it, they still. So those are the things. It doesn't. We never appreciate the sensation until we don't have as much of it. Because sensation is what guides us how much motor function we're gonna do it. So you have a cup. Either you're gonna drop it because you don't hold it tight enough, or you just squeeze on it, and then so you have better use these, very hard cup. And then it will cause injury to the joints because you're always squeezing it like crazy, and the joints don't even tell your brain how much pressure is on it. So it's very easy to damage your joints because you're always just like going crazy, and your brain doesn't even know you're doing that.
I was
those
worried
are-
about my legs earlier that I was doing that, but I don't think I was.
Yeah. Those
worried.
things. But being 38 is your best asset.
All right.
I wish you're
38.
18, but
Yeah.
38 is good. 38 is good.
Yep, I'll take it.
Any other questions?
That's good. 6 months, you can go back.
Just like that.
Be positive.
That's right.
Be dancing around. Dance at your wedding.
That's right.
Any other questions?
No.
No, all of you travel out of state. You
No,
stay
we-
here,
Mom,
right?
We live up
Dad.
north of the
We live close by.
They live close.